Okay, thank you everybody for coming. I'm going to share my screen in a sec, but just wanted to say thank you everyone for coming, and so excited for our conversation today with Amanda. I'm going to share my screen here, but before I do that, maybe I'll just introduce myself. My name is Shauna Jewer, and I work for Nova Scotia Health in a project called Roots of Hope. It's a community suicide prevention initiative that's all about building capacity in our communities to help support those who are contemplating and those that are grieving from suicide. And so happy that you're here with us today. I'll share my screen and just to get us orientated there. All right. There. All right, so Roots of Hope, for those that aren't familiar, is a project that's through our Mental Health Commission of Canada. There's about 20 sites across Canada in different communities. It is very much of a community initiative, so every community looks a little bit different in how they initiate Roots of Hope. And I met Amanda through Roots of Hope, and Amanda is been part of the work that's been being done in the Waterloo area, and she's going to be sharing more about that in a second. I wanted to start off by just doing our land acknowledgement here and to acknowledge that we are situated in Mi'kmaq, the unceded and ancestral territory of the Mi'kmaq people. Unceded means that the Mi'kmaq have never relinquished, sold, traded, or transferred ownership of their land to the European settler colonies, yet land was taken over without their consent through various processes of settler colonialism. This territory is covered by the treaties of peace and friendship, which the Mi'kmaq and Wolastoq people first signed with the British Crown in 1726. These treaties did not involve the surrendering of rights to the land and resources they have traditionally used and occupied. We are all treaty people. And I want to further acknowledge that Nova Scotia is the birthplace of Black culture and heritage in Canada. People of African descent have shared these lands for over 400 years, and over 50 strong and resourceful African Nova Scotia communities exist today. And I'm committed to the struggle against system oppressions that have resulted in profound inequities and the denial of self-determinant rights. I am working actively to deepen our learning at the individual level, providing learning opportunities about anti-racism and decolonization, and to develop partnerships with organizations serving and led by underrepresented groups. Okay. So, I wanted to make sure that we just make note that we are talking about suicide prevention. Amanda's going to be talking about her experience in the Waterloo area and doing research on that. So we won't necessarily be talking about people's lived experience in that, but also noting that there are folks in our space here that have lived experience, and we want to make sure that everyone takes good care of themselves. So I offer these helplines here, the Provincial Mental Health Crisis Line, as well as Suicide Prevention Line. So if anybody needs time to take away from the screen, take a break from it, this is being recorded, so there's always opportunity to see it again, but do take care of yourselves, and I'll also be staying on after our presentation with Amanda and our time together, if anyone needs to debrief or talk afterwards. So I just mentioned a little bit about Roots of Hope, and so just to bring context to our conversation today, Roots of Hope works with 5 pillars of specialized support. So those are programs and services that are supporting those that are contemplating or grieving from suicide, training and networks, public awareness campaigns, means restrictions, and research. And it's our 5th pillar under research that brings us here today to understand what we can do to better understand suicide prevention efforts and what we can do on building our community knowledge in this space. I always like to just talk a little bit about who is here with us and in our online space, because we will be doing some breakout rooms. And so it's always nice to have a sense of who's also sharing our space today. So this was done just yesterday, so it may not reflect completely everyone who is here, but for those that are registered, about a quarter of us have lived experience. So we either have known somebody to be contemplating or grieving, or have contemplated ourselves. About half of us are mental health professionals, half of us work in the nonprofit sector, and half of us are brought here because we're really interested in community research. So and of course, within those categories, there's lots of intersectionality. So we could be from the nonprofit sector and have lived experience, for example. And here's just a breakdown of where we're from. So we have a good part of us that are from the central zone, which is the Halifax regional municipality area. And then in the northern zone and the western zone, 6 and 4 people registered from that area. And about 11 of us come from outside of Nova Scotia. So we're missing folks from our eastern zone. So hopefully we'll be able to get connected to those that are living out in Cape Breton and out that way too. And as far as being familiar with community-based research, we're kind of sitting in a slightly familiar, somewhat familiar area. So we've kind of heard about it, maybe know a little bit about it, but Amanda's going to help us bring us up to speed a little bit on what community-based research looks like. So excited for that. And just the format for today is Amanda's going to take us through a presentation of her work in Waterloo, and then we'll break out into small group conversations to kind of just give time to reflect and think about how Amanda's work can relate to our work here in Nova Scotia. And then we'll come back together for any final questions and comments. Okay, so let me introduce Amanda. So excited that she's here today with us. Amanda has been conducting community-based research in mental health and suicide prevention fields for over 8 years and has developed and delivered various workshops on community-based research for audience such as academics, post-secondary students, youth, and community members. She currently acts as the program coordinator for Community-Based Research Canada and as the provincial evaluation lead for Roots of Hope pilot sites in Ontario. And she's doing all this while also doing a PhD in public health and evaluation as an evaluation specialist. So Amanda's a super busy person. And I'm just going to stop sharing my screen here now. So thankful that you're here with us today, Amanda, and taking the time to be with us. And I'm so excited, folks, for you to meet Amanda, because I've had the pleasure of talking to Amanda a few times. I always learn so much from her, and she's just a wealth of knowledge. So without further ado, Amanda, are you ready?
Yes. Thank you so much, Shauna. I'm happy to be here and to be chatting with you and everyone here today.
Excellent. So to start off our conversation, tell us why you think community-driven research is so important in helping us develop our understanding of suicide and suicide prevention efforts.
Of course. So I'll talk a bit first just about what we mean when we say community-driven or community-based research. So when we talk about community-based research, we're talking about research that's usually done within communities as opposed to within academia. It's research that's really driven by communities. So community members, community organizations will identify a need and initiate a research project. So instead of that project being kind of expert driven or initiated by the ideas of researchers, the research is really driven by the community itself. Community-based research is also participatory. So it involves kind of an active sharing and collaboration between researchers, academics, community members, those with lived experience, and other stakeholders. So these stakeholders will all equitably share the control of the research instead of it being owned or controlled by institutions or academia. And lastly, community-driven, community-based research always aims to be action-oriented. So it's research that will actually create positive social change, not just research that's going to be published and kind of live in academia land without having an impact on the communities that you've worked with. So knowing that, the reason that I think community-based research is so important to suicide and suicide prevention efforts is that it really is a new and different approach to suicide research that we haven't seen a lot in dominant research in suicide in the past. Most research in that suicide prevention field tends to focus a lot on individual pathology. So we know a lot about the risk factors, the demographics, these individual level factors that can contribute to suicidality. But when we look at research, or when we research suicidality in this way, we're almost saying that we believe suicide is a problem of individuals. And I don't believe this, and I'm sure many of you are here because you don't believe that either. So when we do research from this community-based approach, from this community lens, we're acknowledging that suicide isn't just an individual issue, it's a community issue. It's a public health issue as the World Health Organization defines it. So when we do this type of evidence-based research within communities, we are acknowledging the needs of the communities. And we're acknowledging that there's a need for evidence and research that takes a community-based approach. We're really embracing this new definition and understanding of suicide as a community level issue and approaching it in that way, which I think is essential to effective community suicide prevention. I also think when we take this approach, it brings in perspectives that are often missed in traditional research, such as the lived experience knowledge, or even the service provider knowledge. It's very rare in academia and traditional research that we actually hear from service providers, the individuals who support people living with suicidality, or that we hear from those with their own lived or living experience, such as people who have attempted suicide or lost loved ones to suicide. And these perspectives, in my mind, are essential to being able to shape community suicide prevention initiatives, therefore essential to include in our research. Lastly, because community-driven research tends to be so action-oriented, I think when we approach research in this way, we're allowing for that action to come from the research more naturally. We're really committing ourselves to the community. As a researcher, we're accountable to the community. When we enter into community partnerships to do research, we're making ourselves accountable to follow through and to ensure that the research leads to change. Instead of, again, this research just kind of living in academia land. So I see community-based research as kind of a solution to bring together community perspectives, lived experience perspectives, different types of knowledge and understanding under this umbrella of research that we can all share in collaboratively.
Yeah, and I think that that's such a key point. What I have noticed with so I've been working with Roots of Hope for about a year now, and trying to draw on evidence-based research in community space is really challenging because a lot of the research is around interventions and post-tests, pre-tests, and this sort of thing. And that research that's done from a clinical perspective. So these are clinical interventions. So trying to understand how do we help build community capacity with research is challenging because there's a lot we still need to figure out and know. Yeah. So I'm so excited to hear more about the work that's happened in Waterloo because, you know, in Nova Scotia, we are, I feel like still in the very infancy stages of building up a strong community-centered suicide prevention and, you know, lens to things. And Waterloo was kind of in that position at one time and has built this, you know, infrastructure of supports and resources and that sort of thing. And the research has been a big part of that. So, so I'm really curious about learning more about the research that has been done through the Waterloo Region Suicide Prevention Council and what that's looked like.
Yeah. So this is where I'll share my screen with everyone, and I'll walk you through some of the work that we've done here in Waterloo Region in Ontario, doing community-based research to really inform our local suicide prevention efforts. Before I jump into this, I'll just talk a little bit about the Waterloo Region Suicide Prevention Council to give you some context about the community organization that initiated this work. To start, the Waterloo Region Suicide Prevention Council is a small local grassroots nonprofit within Waterloo Region of Ontario. Waterloo Region is situated on the Haldimand Tract, which is the land granted to the Haudenosaunee of the 6 nations of the Grand River. So the Waterloo Region Suicide Prevention Council works within the traditional territory of the neutral Anishinaabe and Haudenosaunee people. If you don't have a sense of Ontario geography, Waterloo Region is in southern Ontario, about an hour from Toronto. It's kind of a mix of 3 urban centers, Kitchener, Waterloo, and Cambridge, and a surrounding, I think, 6 rural townships. The Suicide Prevention Council itself is comprised of community members. This involves those working in the social service sector, those who provide suicide prevention supports and services. It also includes people who represent school boards, post-secondary institution, our first responder groups, firefighters, police, such, and lived experience perspectives, of course. So individuals with lived and living experience of previous suicide attempts or suicide loss. These individuals, all these community members from differing perspectives, sit around our council and inform our work. the Suicide Prevention Council decided to embark on a research project and to initiate a research priority committee in about 2018. And out of this was spurred our research priority project. This project had one main purpose. We really wanted to better understand the demographic risk profiles of those who have attempted suicide and those who have died by suicide in Waterloo region, and to use this information to drive future suicide prevention strategies. So instead of relying on, data and statistics that was provincial or national or global, we really wanted to understand our local context, both for risk profiles, those who are dying, those who are attempting, but also to understand the local context of community services in our area. We did this by pursuing three main research questions. We wanted to understand who is dying by suicide in Waterloo region, who is attempting suicide in Waterloo region, and how people in Waterloo region can be better supported when contemplating suicide. So really focusing on understanding this local context. This research project really was a community collaboration. So as I said, it was initiated by the Waterloo Region Suicide Prevention Council, which itself is a community organization full of community members. We also had a steering committee as part of this research project who informed and drove the research, who had ownership over this research. The steering committee involved local suicide prevention experts. It involved our local public health department. It involved individuals who had lived experience of suicide loss, as well as those with lived experience of suicidal behaviors. We had post-secondary students, we had local service providers, and we had local researchers. We actually did not have anyone officially affiliated with academia as part of this project. So it really was community-based, community-owned. The researchers on this project were part of a community organization called the Center for Community-Based Research, which are experts in community-based research across Canada. So individuals who do have the training, the PhDs in research, but who have chose to work in community-based environments instead of within academia to really dedicate themselves to community-based approaches to research. Our research design involved two phases, a quantitative phase of research and a qualitative phase. We had kind of different titles for these two phases of research. So the first phase was called a community profile on self-harm and suicide. And in this phase, we undertook an epidemiological study with the region of Waterloo Public Health to understand the demographics, the risk profiles, and just any data available to help us understand our local context. And in phase two, which we called It Takes a Community, this was a qualitative phase of research where we looked at understanding service provider perspectives. So we looked to fill the gaps. We know that the data out there doesn't tell us the whole picture. We know that certain individuals or perspectives are not represented within that data. So we wanted to go above and beyond that data to recognize that sometimes evidence is broader than just what statistics can show. Evidence does include the knowledge of those who have on-the-ground experience, who provide the services and supports and work with individuals who have suicidality. So that was why we really, really wanted to focus on that second qualitative phase once we had a base understanding of the data available. So I'll talk a little bit about both of these two phases. The first phase of community profiles, we tried to get our hands on any data sources that we could to help us understand our local context. So of course, some of these sources would be familiar to you if you have ever used or accessed data sources. So the Vital Statistics database through Statistics Canada, that tells us about deaths by suicide. We accessed that. We access data from the Office of the Chief Coroner of Ontario, which provides supplementary information on deaths by suicide. We accessed information from the Canadian Community Health Survey, which is a survey given to all Canadians asking about mental health and suicide, as well as many other health indicators. In Ontario, there's another similar survey called the Ontario Student Drug Use and Health Survey that's given specifically to students. We also pulled data from the National Ambulatory Care Reporting System, which gave us information about hospital visits, emergency department visits for self-harm or intentional self-harm. Two kind of more unique and innovative data sources we were able to tap into that we haven't seen many other communities use or tap into. One was looking at local service provision data. So in our area, the Canadian Mental Health Association for Waterloo Wellington is really the main access point for suicide prevention care. They provide they operate the crisis line here called Here 24/7. So we really wanted to look at their service data to get a sense of what they're seeing that may not be captured in the other data sources. And we also accessed police data, which gave us kind of another layer. Individuals who die by suicide or who attend the hospital for suicide attempts may represent only kind of a small sample of those who experience suicidality in the region. So by also looking at the police calls for individuals who were experiencing suicidality, thinking about suicide, attempting suicide, this cast our net a little bit broader and added another layer that we hadn't seen used before to really understand local communities. Key findings from all of this, I won't go into it too much in depth, really nothing overly surprising. Males had an average rate of suicide 3 times higher than females, which is consistent with provincial and national trends. Suicide mortality peaked in men around the ages of 50 to 59. The groups with higher rates of self-reported suicide behavior included females, youth, people with lower income, people with less formal education, people who were single, never married, divorced, widowed, or separated, Canadian-born individuals as opposed to immigrants, Indigenous peoples, and lesbian, gay, or bisexual individuals. So nothing overly surprising there. However, it was good to just know that those were relevant to our community context. What was really unique about our local community context is that the emergency department visits for intentional self-harm were rapidly increasing in our region, particularly for young females, and were higher than the average rates for Ontario. So this was a really interesting, really kind of contextually nuanced finding about our community specifically. The gaps, of course, in this information were that we didn't have really much information around precipitating factors or events or just any of the life circumstances of these individuals, aside from those kind of demographic profiles. Even within the demographic profiles, there was really limited information. The demographics didn't tell us, for example, if those who were dying or attempting were post-secondary students. It also didn't tell us anything about transgender individuals. Any of the data sources we looked at collected information only on sex, but not on sex and gender. So any type of analysis like that wasn't possible. We also don't know why we're seeing the trends that we are seeing. And particularly of interest for us was these ED visits. Why are these visits rapidly increasing and why are they higher than the average in our area? No answers to those questions could be found in the data. And there was also limited information to really help inform our preventative action here. So we dove into that much further with our qualitative study, which we called It Takes a Community. In this study, we conducted one-on-one interviews with 25 service providers in the area of counseling agencies, health and social service, and education. So we interviewed people working in community nonprofits, we interviewed people in the private sector, we interviewed public health, social service representatives, we interviewed first responders, and we interviewed school staff within our public secondary schools as well as our post-secondary institutions. What was really unique about the way that we approached these interviews is we relied on community researchers. So in the spirit of really doing this in a community-based fashion, we had our steering committee that I mentioned earlier that guided all of this research, helped us decide upon who to interview, how to interview them, what questions to ask them. But we also then actually asked our steering committee members who would like to do this research. And a subsection of our steering committee said, yes, I would like to be a part of actually doing the research. So we trained these individuals on how to conduct interviews, on how to analyze the data, and we really gave them ownership over this. We made it highly participatory. So we were also then building the capacity of these community members, these service providers, these individuals with lived experience. We were teaching them how to do research, building their own skill sets, as we, as the researchers, were also learning from them about how to best do research in a collaborative fashion, how to best do research in a way that does integrate that lived experience knowledge. The findings out of this qualitative research did indicate that post-secondary students, and particularly international students, were seen as being at higher risk, as well as LGBTQ youth. So these were two populations, remember, that we had no information about from our data, our statistics, but by talking to people, they largely agreed that post-secondary students and trans youth were individuals that they were seeing at higher risk for suicide. They also identified older males at being higher risk when this wasn't necessarily shown in our data. We also learned a lot about the kind of life situations or precipitating factors that service providers saw in people who were experiencing suicidality. This involved things like complex trauma, mental illness, substance use, lack of employment or housing, lack of social supports, and long wait times that were being experienced. We also, again, learned a lot about our unique context here in Waterloo region to help us really understand the questions of why and what's unique to us. So in Waterloo, there's been a very unique shift in industry over the past kind of decade or two, from an industry that used to be very much focused on manufacturing to one that's now very focused on kind of tech sector and innovation. So this created kind of a period of job loss, a period of job shift. In our area, we also have highly competitive post-secondary programs. So in this small region, we have two universities and a college that have many different campuses. And one of our universities in particular is known as being kind of very high pressure, very competitive. We also have quite a large wealth disparity in Waterloo region, rising housing costs, more so than the average for Ontario. And when we talked to community service providers, they saw our region particularly as having very siloed community services. So those working in suicide prevention and housing and employment and income didn't always talk to each other, didn't always create kind of seamless circles of care for individuals who may have needed more than one service, or for individuals who are aging out of certain services. So what impact did all of this have? We learned a lot about our local research context, and we learned about it in a way that really embraced this community approach, which I would argue is why we were able to learn as much as we did, and also why we were able to translate those learnings into action. So what were these actions? Because the Waterloo Region Suicide Prevention Council is a well-known social organization, nonprofit in the region, they do have strong partnerships, and we're able to initiate a lot of new action from this research. One of the actions they initiated was to build stronger partnerships between themselves and post-secondary institutions and 2S LGBTQ agencies, because this was identified as a gap. The Waterloo Region Suicide Prevention Council also created a community roundtable where we bring together people working in the mental health, the social service, the first responder, and the education services to try to reduce these silos that people identified our community as having. We also really wanted to look at this mystery of emergency department visits in our region and to try to start solving that issue. So we followed up with a new research project that explored emergency department experiences and uncovered suggestions for how we can better support individuals who attend the emergency department because of suicide ideation. We wanted to look at kind of this idea of post-secondary students and youth and these young females who are experiencing really high rates of emergency department visits. So we wanted to design an initiative that focused specifically on youth. With this, we went through this lengthy process for anyone who's tried to get into the school boards, but eventually we were able to get into the school boards and deliver mental health education, wellness presentations to every grade 8 class in our region, which was a huge feat, a huge accomplishment. And directly from this research, we were able to support why we thought this was necessary to get in with the school boards and to get them on board with this presentation. We also designed, or didn't design, but we adapted and piloted a new means restriction tool to be used within the hospitals to try to prevent youth suicide attempts. And lastly, because of the information we found suggesting that individuals who were of low income or of social housing potentially had a higher risk, we developed training and awareness that was specifically targeted to individuals living in social housing. So we trained individuals in Safe Talk and Assist and delivered education presentations to staff of social housing and individuals living in social housing to try to increase their own capacity to support suicide prevention initiatives within their own community. So I'll stop sharing my screen now. I kind of went through a lot of information there, but I hope this gives you a sense of how we implemented a community-based research project in Waterloo region, what we found from that project, and how that project helped us to really shape our suicide prevention initiatives locally.
Okay, perfect. Thank you, Amanda. All right, do you want to stop sharing screen now, Amanda? I can see you there. So thank you so much for that. And I think, you know, why I was so excited to have you share your experiences with us is that in Nova Scotia with Roots of Hope, you know, I tell people I'm not coming with a project or an intervention or a service or program or a toolkit. I don't have pamphlets. I don't have, you know, fact sheets. You know, I'm not coming to the communities with anything that this is how this has to happen. And really keen on understanding what is happening in our communities so that we can design something that works in relation to the community, that's within the context of that community. And so sharing with the work that you've done with Waterloo to have a better understanding of that, and then demonstrating how that leads to action was just so brilliant. So I thank you so much for that. There was a couple of questions. One was around the age range of the young women, and I think that was in reference to the young women cutting was something that had shown up in your research. Can you clarify just kind of what the age range for those girls were?
Yeah, off the top of my head, I'll say I don't remember, but this can be found. One of the slides I had shared had the cover page for our community report, a community profile on suicide and self-harm in Waterloo region. So that report is publicly available through the public health department. So if there were questions you had specifically around the data like that, you could look that up, and I can hunt that link down and put it in the chat.
Here, I think I've got it right here. I think Amanda, so is this the report that you had a picture of there? Yeah,
that's
okay.
Exactly it. Thank you.
Perfect. I'm prepared for this, Amanda, because I know people will want to know more about this. So there's the link to that report there. And there was also a question around with the intervention, with the workshop that was developed for the youth, and you honed in on grade 8 students. Was there a reason why grade 8? Was that from the research itself, or was it a school board thing, or how did that come to be?
Yeah, so there was a reason we decided to focus on grade 8s. One of the other, it wasn't necessarily hard data that came out of any phase of our research, but one of the things we started to really consider, both from what we learned and from some of the research coming out about suicide, is this idea that transitions are time when individuals might experience increased risk of suicidality. So that idea of a transition from, grade 8 to high school, we thought we want to better prepare individuals to get through transitions that may be difficult by providing them with this mental health education, this promotion before they go through those difficult transitions. So it was kind of in the spirit of doing upstream prevention instead of, doing it in grade 9 when students have gone through that transition and potentially are already stressed. Can we give them tools to build their capacity, to build their coping skills and strategies and things like that while they're in grade 8 to potentially make that transition a bit smoother? So that was kind of our thinking to do grade 8 instead of grade 9. And in terms of why grade 8 instead of younger than that, most of our presentation didn't touch directly on suicide. It was really upstream mental health promotion, but we did talk about suicide as well, just to say, here's how you can support someone, here's how you might recognize if a friend is struggling. And our message to that age is always, don't do it alone, talk to an adult. But the school board, that was kind of where the school board had thought about safety. And we thought, we don't want to start talking about that to anyone younger in large groups. So they, in consultation with us, decided grade 8 might be a good age to do that and bring that in. There were, a whole bunch of other safety measures that we put in place to really make sure those presentations were a safe space and that individuals were supported and had the clinical support if they needed it, and all of that as well. But that's a whole nother conversation.
Yes. Well, and I feel like this is just the beginning of many conversations, but we have a couple more questions before we go out to breakout groups. One is, are the training and awareness materials targeted to individuals living in social housing available for share public? Are they publicly available?
Nothing that we have developed is quite finished or publicly available. We're still kind of in the process of developing our own targeted materials for that. But what we have done in that, what is publicly available is just that we did utilize the LivingWorks trainings. So we weren't able to run safe talks at the time because of the COVID-19 measures. So we instead used a new LivingWorks product called START, which is a self-paced asynchronous online module that teaches people how to recognize someone who might be struggling with suicide. So we paid for individuals to take that training within that context. So that's what we've done so far. And then our more targeted awareness materials that we plan on developing will be coming next. But what we're planning on doing there is developing brochures and things like that can go in the lobbies and the elevators and common spaces of the social housing that just talk roughly about what services and supports people can access and how you might know that you're struggling or that someone might be struggling. So that kind of general educational and awareness material.
Okay. I love that how from the research, there is so much action items coming from it. And it gives you kind of a path forward of what to do next. Because that's sometimes the conversations I'm in is, well, what are we going to do? How are we going to do this? Like, what should we be doing? And when you do the research and have an understanding of what's happening, then I feel like the path becomes a lot clearer of where to go with the next step. Okay, I'm going to squeeze this one last question in before we go into breakout groups. So how did you navigate the different data collected by different sources? Were you still able to compare them? Did you make recommendations to source about data that could be collected?
Yeah, a couple kind of really complex questions all rolled into one there.
Yeah.
So in terms of navigating, the different data by different sources, I won't go too much into our data analysis process, but once we had our qualitative data, we did kind of analyze initially by stakeholder group. So, what were these stakeholders saying? What were these saying? What were these folks saying? And then we looked at trends kind of across the different groups. So we did look at, and the findings I shared here were kind of the findings where there was the most level of agreement. What we haven't done a lot of yet is looking at where there were trends or not even trends, but just sentiments that were shared by some people, but not others, and kind of teasing that out a little more. So as much as, the research is done being conducted, we're still as an organization, because as the nonprofit, we had ownership of this project, we can continually kind of look at that data and use it to inform us moving forward. So I'll say that's an ongoing process of still kind of comparing the data, thinking about how we can use it in different ways. In terms of making recommendations about data that people could be collecting, yes, we really hoped that we could be a strong voice of advocacy for things like the coroner's office. Why isn't the coroner's office collecting data on sex and gender? Why aren't the hospitals collecting information on sex and gender? Why isn't information on race or culture, ethnicity, anything like that being collected? Why isn't, status as a post-secondary student being collected? So we started questioning, why isn't this data being collected? How can it be collected? And here's why it's important for us to know this data. Because when you don't collect certain demographic data, and when you don't collect it in an intersectional way, people aren't represented within the data, and then it's less useful for community organizations that really want to mobilize it. So we have in our report, we talk a little bit about how we would like to advocate for data. I'll say we haven't been able to do a lot of that yet because of just our internal capacity, but it is kind of a torch that we hope to continue to carry, and that our public health department also is very motivated to continue to carry as we advocate together for better data collection.
Okay, Perfect. And there is a couple more questions, but I'm going to just pause there because I do want to give people an opportunity to just break out for a small bit, just to get a sense of who's in the space and have a chance to reflect on it. So I'm just going to stop the recording for a second here. Perfect. So I think a lot of great conversation was happening in those breakout rooms. Amanda, I saw that you were talking just as we were coming out of breakout rooms. Did you get to finish your thought with the group, or is there something you could share?
We were just saying thank you and goodbye to each other.
Okay, very good. Excellent, excellent. So thank you everybody for coming today. I'm going to put in the chat here a link to the evaluation. And if people want to take a few moments to fill that out, that would be great. At the very end of the evaluation, there's a question around anything else that you'd like to learn. So this was a very quick presentation, a quick overview of Amanda's work in Waterloo. There is so much more we could dig into. If people are interested in learning more, please let us know so that, let me know so that we can then plan further conversations and build a bit deeper understanding. And I'm just going to acknowledge this question here that Emily had put in the chat. And I think that this could be another talk that we could have, Amanda, but Emily was curious around describing any experiences and successes in layering the quantitative and qualitative data. So for example, interviews discussing economic hardships and the disparities in suicide rates across income quintiles. For enhanced uptake by all stakeholders. So that, again, another large question.
Yeah, very complex question about data analysis. So,
yes.
We really used a combination of inductive and deductive analysis. So sometimes we kind of inductively looked at the qualitative and said, what do we find here? And then is there any data to support it? Sometimes it was very deductive that we said, here's what the quantitative has said. Where's the evidence of this in the qualitative? So we really did kind of combine to be able to have both types of evidence. The importance of that, part of this question was about enhancing the uptake by all stakeholders. So we do know when you're talking to different stakeholders, there's different types of evidence or different language you need to use to reach different stakeholders. So by having that layering, by having the mixed methods and the triangulation of the qualitative and the quantitative, we were able to speak different languages in the way we presented that data. We were able to, throw the hard statistics at the policymakers who responded more to that. We were able to share quotes and sentiments with service providers who would be more touched by that type of information. We were able to layer it all together in a short infographic summary of the research that was provided to community members. So, there was a lot we could do there in terms of the summarizing of the data in different ways once we had analyzed it in kind of a mixed methods fashion. But, that's a whole research methods course on mixed methods analysis.
Right.
I am happy sharing my email address with folks if anyone would like to follow up with, small questions. Shauna did mention, I'm quite busy. But I'm always happy to talk about this. This is the suicide prevention work, and specifically suicide prevention from a community-based perspective is my biggest passion out of everything else that I do. So I'm happy to connect with folks who have questions and happy to hopefully stay connected with Shauna and hear some updates on how you all progress in your work in Nova Scotia.
Yes, thank you so much, Amanda, for your time. Thank you so much for sharing your knowledge with us today. I think we've learned a ton, given us a lot to reflect and think about, and really try to, hopefully we've generated some interest in Nova Scotia here to explore what we could be doing with community-driven research here. Thank you everybody for coming. I'm going to throw in the chat again that evaluation. Again, let us know if this was of interest to you, if you would like to know more about this, if you'd like to explore this as a possibility in Nova Scotia here, do something similar as Waterloo had done. I'd love to hear about that, and take care, everyone. I will stay on. I'm going to stop recording now. I'm going to say goodbye to everyone.